Good morning, everyone. And at the outset, I would like to thank all the organizers for giving me this opportunity. It's indeed an honor to be taking this talk with stalwarts like Dr. Khan and Dr. Gosain and all the other faculty members. Thank you, Dr. Kuto, for that introduction. And my talk today is made much easier by Dr. Khan and Dr. Gosain by their wonderful talks and by apprising you all of the changes that have happened in the new WHO 5th edition 2022 in these endocrine organs of the head and neck region, namely thyroid and parathyroid. And I'll be restricting to the grossing of these organs only. So no financial disclosures, and some pictures in this presentation are from external sources, which has been appropriately referenced. So I will start with thyroidectomy specimens. So learning objectives of this talk will be what, why, and how. So what specimens can we expect? What is the specimen that has been received? Why? Clinically, why the said procedure was done in a particular case, and from a pathology point of view, why a particular pathology warranted that particular surgical procedure, or is the pathology enough for that surgical procedure, or patient needs to get something more? How? Then how to gross different types of thyroidectomy specimens that come to our table, and then how to report them, which is the minimal data set reporting. And this schema will say the same for parathyroid lesions as well. So starting with the that is the types of thyroidectomy that we receive. So it is hemithyroidectomy or lobectomy, total thyroidectomy, isthemectomy, and near total thyroidectomy and completion thyroidectomy. And on the right hand side, you can see that these are the usual principles for why we receive these specimens. So for a less than 4 centimeter classical papillary thyroid carcinoma without any high risk features on imaging or on clinical examination, a hemithyroidectomy will be done. A less than 1 centimeter follicular thyroid lesion or follicular carcinoma or a follicular lesion, a hemithyroid will be done. From 1 to 4 centimeter, the literature is divided. Some people would still go ahead with hemithyroidectomy. Like at Tata Memorial, we would still go ahead with hemithyroidectomy for up to 4 centimeter of follicular thyroid lesions, whereas some people would like to do a completion in such cases. Then medullary, poorly differentiated thyroid carcinomas and anaplastic thyroid carcinomas always undergo total thyroidectomy. So it is important to know the clinical suspicion, the preoperative imaging findings, as well as the preoperative FNA findings that are present in a particular case. Then I come to why. What are the indications for thyroidectomy? So thyroidectomy may be done for benign or inapparent lesions. It may be done for thyroid nodular disease, multinodular goiter, or it may be a genetically determined nodular disease of the thyroid, refractory hyperparathyroidism, large solitary nodule, refractory hyperthyroidism or Graves' disease, large solitary nodule for cosmetic reasons, and a prophylactic thyroidectomy for Men's syndrome. Malignancy, it may be done for malignancy which is FNAC proven. So when you have a definite lesion, then you may have a thyroidectomy. In such a case, it is very important to record the clinical, which is the clinical and the USG thyroid findings and the pathology findings of the preoperative procedures, which may be an FNA in most cases, but also may be intraoperative consultation or frozen section examination. All those findings are very important. Any touch smears, any imprint smears made at that time must also be included in your reporting. Thyroid nodule. FNAC results are suspicious, Bethesda category 3 lesions repeated twice, or indeterminate. And in such cases, the procedure may be diagnostic, that is a lobectomy or a hemithyroidectomy, which may again be received for frozen section or directly for final histopathology. Thyroid nodular disease and prophylactic total thyroidectomy, as I've already said, for Men's syndrome. What are the relevant points that we have to take into account before starting to gross any thyroid specimen? What is the type? It is mandatory to record what was the type of procedure. As I said, what was the purpose of that procedure? What was the indication of surgery? In particular, whether a malignancy was suspected or not, based on any prior surgery, FNA, or intraoperative consultation. And this is also very important, whether there was any prior procedure that was done, any prior surgery. Is this a surgically naive patient, or is this a completion thyroidectomy or some kind of a revision surgery? if available, and I would insist that actually they should be available, that imaging findings, which includes the number of suspicious nodules, their location, their sizes, a good imaging should always be accompanied by when you are looking at a thyroid specimen or or to gross or report a thyroidectomy specimen. And in fact, imaging of thyroid has undergone revolutionization, and they can actually give you scores and tell you risk of malignancy in a particular thyroid nodule just based on the ultrasound features. And this is the American College of Radiology TIRAD system, which is the most commonly used system worldwide, which is based on composition, echogenicity of nodules, shape, margin, and echogenic foci. And they actually give you a risk of malignancy in which 4C and TIRADS 5 are highly suggestive of malignancy, whereas the others have probably benign or low risk of suspicion. So it should be, the thyroid ultrasound should be reported in accordance with these guidelines. And these are the reasons why the nodule may look more malignant, is that solid appearance, taller than wider, irregular borders, microcalcifications, and markedly hypoechoic. So even if the TIRADS has not been mentioned in your ultrasound thyroid report, please look for these features in the thyroid ultrasound report in the particular case when you are looking at a thyroidectomy specimen. Then this is our own data from Tata Memorial, where we came up with this new classification system on imaging, which is known as the TMC RSS score, which had a very high sensitivity and specificity to identify malignancy and characterization of thyroid nodules. And this is also used in multiple places in the world. And this is a combination of TIRADS, vascularity, and elastography, Doppler and elastography, and has a very high sensitivity and specificity. All to tell you that imaging findings are very important before we start grossing or start looking at a thyroidectomy specimen. And coming to how to gross a thyroidectomy specimen. So as you can see, this is on the right hand side is a total thyroidectomy specimen. Identify the type of specimen, laterality in case of lobectomy or hemithyroidectomy. That must be done. Type of specimen, orient the specimen. For orientation, identify the isthmus, which is located inferiorly to the two lateral lobes. So identify the isthmus, which is located at the lower part of the two lateral lobes, and must remember that thyroid on the anterior surface is convex or bulging, and on the posterior surface is convex, and that is concave, is concave. And that is how you can orient a thyroidectomy specimen, which is not distorted beyond distorted because of the nodules or because of the disease. And if that has happened, in that case, please ask your surgeons. It is a good idea to mark a suture at the superior pole of one or both lobes in that situation, which will definitely help you then identify and orient your specimen. Or go back to your imaging findings, and that is one more important feature of the imaging findings. Go back to your imaging findings and try to correlate with the size of the lobes and their features on ultrasound for orientation of the specimen. The lobes tend to taper superiorly and are broader at the inferior pole in most cases. Then weigh the gland, it is important. Orient the gland, record the dimensions of each lobe, isthmus, and other tissue attached before slicing the lobes. Then comment on external surfaces, both anterior and posterior. Are there any additional findings? Is there any attached strap muscles? Are there any other attached structures? Is there fat associated? Do you have any nodes around the isthmus region? All those features have to be described and made an account of in the gross recording. Then anterior surface is convex and encapsulated, as I said. Appearance, nodular or bossylated, all those have to be. Then what is the appearance of the external surface? Is there unilateral enlargement, presence of any nodule or cyst? Please look at your right. This superior pole has been marked, as I said, with the thread. This is the left lobe, this is the right lobe of the thyroid. And what you see here as a slit and something that is seemingly, questionable, what is this, whether it's a lesion or not, sorry for this thing, is actually a thyroglossal cyst, which has been diagnosed, and this is a thyroglossal cyst seen on the anterior aspect of the thyroid. And later we will see more sections of the more grossing of this very specimen. Again, capsule, situation of the capsule, whether the thyroid, the irregular thyroid capsule, whether it's intact or breached, any other structure adherent to the gland. Look for parathyroid gland along the posterior surface. And if you can identify grossly, please record the presence or absence or number of glands. Then ink the specimen. As shown previously, it is a good practice to ink the both lobes and the isthmus with separate colors. You can ink the right lobe with the blue color and the left lobe with the black color, and the isthmus with yellow or orange color, as done in this case. This helps easy identification of the lobes in final histopathology as well, and the margins also. So ink the specimen. This is just to show another specimen, another common specimen, which is the hemithyroidectomy. Orient the specimen. As I said, in this case, you might need the help of the surgeon to orient the specimen, preferably asking the surgeon to put a stitch at the superior pole. Ink only the cut end of the isthmus with a different color. If you're trying to ink hemithyroidectomy with different colors, only the cut end of the isthmus and not the entire isthmus has to be inked with a different color. And then serially slice from superior to inferior, whether it's a total or a hemi, serially slice from superior to inferior pole, leaving the different cuts attached to each other. Do not separate the lobes before fixation is completed. So this is just to show a diagrammatic representation. Hemithyroidectomy, only ink the cut surface of the isthmus to identify this as the surgical margin. Do not ink the entire isthmus as a separate color. And then serially slice from superior to inferior. Total thyroidectomy, ink the two lobes and the isthmus separately, and again serially slice from superior to inferior. The isthmus has to be sliced from one lobe to the other, or left to right. Ink, serially slice, and formalin fix the specimen. Formalin fix all thyroid specimens. It is very important in a high volume center like ours, where it is very easy to gross a thyroidectomy specimen the same day because it's a very small specimen and it can be done very quickly. Do not do that. Formalin fix all the thyroid specimens. Always remember that nuclear features are an artifact of fixation. If the specimen is not fixed properly, the nuclear features may not be well developed. So always fix all your specimens. And that is why I said, when you serially slice, do not separate. Do not separate. Separate when you are final grossing the specimen. So when you're grossing it finally the next day after fixation of around 24 hours, then separate the two lobes and the isthmus. Serially slice each lobe and isthmus. Slice the lobes. What is the way to slice? As I said, superior to inferior. If your lesion is less than 2 centimeter, correlate with your USG findings if your lesion is less than 2 centimeter. If your lesion is more than 2 centimeter, then it's a good idea to avoid bulging of the nodule in those serial slices. And then you will not get an idea of the capsule. The capsule will retract and the nodule will bulge. So if your lesion is more than 2 centimeter, first halve the specimen, like you would slice the kidney. Like you would go from the center of this thing, make a half of both the one lobe, and then serially slice them from superior to inferior and submit according to the lesion that you're looking at. If there is a lesion, if there is a discernible lesion, the lesion has to be measured in all 3 dimensions. Though the largest lesion dimension is absolutely important to be measured, but it is preferable to measure in all 3 dimensions of the lesion. If there is a measurable or a describable nodule, then what all factors will you see in the nodule? Of course, the number of nodules, their location, dimension of all the nodules in all 3 dimensions, gross appearance of the nodule, whether it is solid, cystic, what is the consistency, shape, color, and circumscription of the nodule. Is there a gross capsule present? If present, is the capsule infiltrated grossly? Are there multiple nodules outside the capsule? And what is the distance of the capsule, thyroid capsule or ink surface or the margin from the thyroid nodule capsule? Extrathyroidal extension present, absent, and if available, correlate with intraoperative nodes. It's a very good idea to correlate the extent of extrathyroidal extension with the intraoperative nodes, because the meaty brown color of the thyroid sometimes merges with the strap muscle, the brown color of the strap muscle. And when there is a tumor which is infiltrating, there is a fibrous reaction, there may be a fibrous reaction. So small amount of strap muscle may not be very discernible in a gross specimen, and please do correlate with intraoperative findings. And if the intraoperative findings mention gross extrathyroidal extension, which is a very clinically significant parameter, then please go ahead and sample more of the external surface of the thyroid with the surrounding attached tissue, where whatever is available. Then appear, color, and consistency of the adjacent thyroid. Do not forget the adjacent thyroid, and always sample as well as mention the status of the adjacent thyroid in your grossing specimen. So this is to show you the grossing of the total thyroidectomy specimen. So serially sliced from superior to inferior. This is when you are suspecting, you have the previous information of FNA or intraoperative that you are suspecting a PTC, a classical PTC or some variant of PTC. In that situation, you are serially dissecting superior to inferior. You can see the lesion has started appearing, and you measure the lesion, as I said, grossly before you serially slice and lay these out specimen, the sections. You should have measured the lesion in all 3 dimensions, identify the characteristics of this lesion, and in the right lobe, the ultrasound findings described the right lobe lesion, which correlated with what we saw on gross. But also when we serially sliced the specimen, we discovered that there was a 3 millimeter nodule in the left lobe of thyroid, which was not described on the USG findings. And this is an incidental finding, which is very important, because in this situation, looking at the 2 on gross, it seems to be the same tumor nodule and makes the lesion multifocal. And this is just a closer view to show you that this is an incidentally detected 3 millimeter nodule in the left thyroid lobe. And here in this area, you see some brownish tissue at the edge of the tumor nodule, which appears to be the skeletal muscle or the strap muscle. There is very little of this peripheral tissue that is available, and this is suspected extrathyroidal extension. It did correlate with the intraoperative nodes as well, and that is why this area definitely needs to be included when you are blocking your sections, when you are putting your sections in the cassette to look at presence of extrathyroidal extension. And this is again coming back to that specimen which showed you this cystic structure on its anterior aspect. Further dissection showed that the smooth walled cyst is transitioning into this friable papillary growth, which is extending to the left lobe of the thyroid as well. You can see this friable papillary growth, and this is how then we further gross this specimen, where we have again dissected this from superior to inferior. All the entire thyroglossal cyst has been sampled. Again, multiple serial sections, and both the lobes and the isthmus have been dissected from superior to inferior lobe. And we can see that this is a thyroglossal cyst. We can see on the extreme right, the cyst wall, which is transforming into this solid area. And this area is also showing papillary excrescences. So this is actually a case of PTC classical arising in a thyroglossal cyst, which is also extending to the thyroid lobes. This was for classical PTC, when you have an idea that you're dealing with classical PTC or any of its variant. The grossing protocol will change if your preoperative FNAC suggests a Bethesda category 4 or a follicular neoplasm. In that situation, as I said, most of the times what you'll receive is a hemithyroidectomy, and this is just to show you the hemithyroidectomy specimen. This is what I said by meaning that you have to halve the lesion when you have a tumor which is more than 2 centimeter to avoid bulging of the nodule in your sections, and in that will make it improperly sectioned later on, so that the capsule will not be appreciable. And after that, the grossing protocol remains similar till the fact that superior to inferior serious slicing of both the halves has to be done. However, after doing that, this area, which is the interface, you can see this is a very nice encapsulated lesion, And here the capsule is becoming the thickest. So these areas of the capsule and all the areas of the capsule have to be sampled. So it is essential to submit. I cannot emphasize this enough, that it is essential to submit the entire tumor capsule in an encapsulated lesion. And these areas of thick capsule have to be especially serially sliced at 2 to 3 millimeter intervals, and thin sections of these areas to submitted them entirely. This does not mean that each of these sections has to come on a single slide. And I've just to show you, this is a pictorial representation that how you can put different sections of the capsule. These are three different peripheral areas with the capsule and the surrounding thyroid. And I put them on one slide like this, like a crescent moon. So multiple slices of the capsule, I'm sorry, can be put on one single slide, but do not fall short of sampling the entire tumor capsule. It is absolutely essential in a hemithyroidectomy for a solitary or multiple encapsulated nodule of the thyroid. So this is just the show you diagrammatic representation, sorry, of the same thing. It is essential to submit the entire tumor capsule, submit the central part as well, because it is the central areas which show papillary architecture. So when you submit the periphery, you look for capsular invasion, you look for angio invasion, you look for criteria of malignancy. But when you submit the central area, you help in subclassifying the lesion, because that is where many a times your papillary areas might be sitting. So as Dr. Gosain has already said, 1% papilla, more than 1% papilla changes the criteria. It cannot be a follicular lesion anymore. Though up to 10%, he showed the data that up to 10% papilla does not lead to lymph node metastasis. But as per the criteria, 1% more than 1% papilla is unacceptable for follicular lesions. So what are the sections? Once you've done the grossing in this manner, what are the sections? Again, the sections are determined by what were your gross findings. So that is very important that you gross it properly. If there was no focal lesion, then each lobe at least 3 sections, isthmus 1 section, and multinodular thyroid gland, each nodule at least 1 section, including rim and adjacent normal. You can never predict which one of those nodules may actually harbor a neoplastic lesion. So that is why it is all those individual nodules have to be sectioned as if they can later on turn to be neoplastic. Additional sections from nodules with thick capsules. This is very important, or heterogeneous appearance. Submit sections from all foci of white cream tissue. The moment the previous grossing I showed you, the lesions were white and cream, that is high risk for malignancy. And all such foci of white cream tissue have to be submitted, as they may represent cancer. What about solitary encapsulated follicular lesion, like the last picture where you clearly see a lesion? Less than 3 centimeter, submit the entire lesion. In thyroid, the more the better. Please follow the protocol, the more the better. More than 3 centimeter in maximum dimension, alternate serial sections or 1 section per centimeter of the lesion. I would say try to do as much as, I would say 2 sections per centimeter at least, or if possible, if it is a if it is acceptable for your lab, then try to sample as much as possible. As I said, more is better. Regardless of the size of the lesion, submit the entire tumor capsule demonstrating relationship with the adjacent tissue. There is no shortcut to this. The entire tumor capsule has to be submitted. Non-lesional tissue has to be blocked, further blocks from each lobe and 1 from the isthmus. Non-involved lobes, 2 blocks from each lobe and 1 from the isthmus, even if they are seemingly uninvolved. For suspected cancer, papillary, medullary, or undifferentiated, less than 2 centimeter, submit all tumor tissue. More than 2 centimeter, again 1 section to 2 sections per centimeter. As I said, the more the better. Non-lesional tissue, 3 further sections from each lobe and 1 from the isthmus. Prophylactic thyroidectomy for suspected medullary carcinomas, submit all tissue. Those thyroids are usually small, the lesions are grossly inapparent, and hence it is a dictum to submit all tissue. Completion thyroidectomy in a known case of malignancy, submit all foci of white cream tissue. Better to submit all tissue for processing if possible in your lab, but definitely submit all white cream tissues. Other rare inflammatory conditions may also require extensive sampling of the thyroid to look for small foci of incidental malignancies. Then, and you cannot ignore the lymph nodes and additional tissues that have come with the thyroidectomy specimen. Lymph nodes, record them separately. The ones retrieved from the resection specimen, again describe site and the number, and then separately submitted. Collective size of 3 dimensions, grossly identified lymph nodes, and maximum diameter of each, and if they are grossly involved or not. Adjacent tissues such as fat, skeletal muscle, and parathyroid glands, and note any extension of tumor into these tissues. Coming to minimum data set reporting of thyroid, it is basically a combination of 3 things. The 8th edition AJCC staging protocol, which is the T, N, and M classification. Again, further subdivided, the T and M of the thyroid is dependent on the histological subtype. It is different from papillary, medullary, and anaplastic thyroid cancer. But this is what we take into account when we are reporting the minimal data set. The newer WHO classification, about which you heard in detail already from Dr. Gosain just a while ago, the newer classification, and the ATA risk, or the American Thyroid Association risk stratification of thyroid lesions, which for the first time actually took into account the histological parameters. The histological, for example, aggressive subtypes of PTC, tall cell, columnar cell, hobnail variant, then BRAF mutation present or not, then what is the multifocality if it is present or not. Minimal extrathyroidal extension on microscopy has no ATA risk stratification significance. However, gross extrathyroidal extension changes the category of ATA risk stratification to intermediate risk, and that is why recording of gross extrathyroidal extension is very important. So a combination of the parameters required for AJCC staging, WHO classification, and ATA risk stratification will automatically give you the minimal data set reporting, including the core and the non-core elements of the thyroid reporting protocol. The core elements, which are the absolute must and must be included in all reports, are the type of operative procedure, the operative findings, the specimen which has been submitted, tumor focality, site, dimensions. In this, the largest dimension is mandatory. All 3 dimensions are preferable. Histological tumor type, mitotic activity, tumor encapsulation or circumscription, capsular invasion wherever applicable, lymphatic or blood vessel invasion. These are 2 separate things. Lymphatic invasion is different from angio invasion. Lymphatic invasion happens in PTC, whereas angio invasion happens in follicular thyroid cancers. Angio invasion is a harbinger of poor prognosis, whereas lymphatic invasion is just a way of papillary thyroid carcinoma to spread to the lymph nodes. Hence, angio invasion is what you are looking for, especially in a follicular thyroid lesion. Necrosis absolute must. Extrathyroidal extension, gross, more important than microscopic. Margin status, whether free or not, whether the tumor has been completely resected or not, because that changes the TNM stage. Lymph node status, again very important prognostic factor and changes the TNM stage. Coexistent pathology, parathyroid gland status if present, histologically confirmed distant metastasis, again important for TNM, and pathological staging, which is the PTNM staging, or the, as I said, AJCC staging criteria. All these parameters are an absolute must. This is just each of these in detail. Mitosis, Turin, and MSKCC. So depending on the case in hand, whether 3 or more mitoses are significant, or MSKCC criteria, whether more than 5 mitoses and or necrosis is important. Differentiation of grade where necessary, as has been told, medullary thyroid, high-grade differentiated thyroid carcinoma, poorly differentiated thyroid carcinoma, presence of differentiated component, and the grade depending on mitosis and necrosis has to be mentioned. Number of tumor foci, angio invasion and lymphatic, as I told you. Classification of angio invasion into less than 4 and more than 4 vessel. Extensive angio invasion is further harbinger of poor prognosis. Perineural invasion is no longer a core element in the thyroid reporting protocol. And these are just to show you the different types of histological subtypes. The first picture on the left is a NIFP capsule, totally encapsulated, subtle nuclear features of PTC, and absolutely no capsular or angioinvasion. Then cribriform morula, the insert shows the strong beta catenin. This is a recent entity, adamantinoma like U-wings of the thyroid. Then tall cell subtype, 3 times taller nuclei than wider. Very well developed nuclear features of papillary thyroid carcinoma. The insert shows the BRAF mutation. These are practically now in 90% cases defined by BRAF V600E mutations, and combination of TERT promoter mutations with BRAF is an indicator of distant metastasis in these lesions and is important. Hobnail subtype, again a high risk subtype, and medullary thyroid carcinoma. So all of these, presence of tall cell subtype, especially in a patient who has been subjected to hemithyroid, if it was a 2 centimeter lesion, but this is a tall cell subtype, BRAF mutated, or a hobnail subtype, you have to inform the clinician that the patient has to undergo a completion thyroidectomy because of presence of high risk features in the final histopathology. And that is why there is importance of each of these histological subtypes as well. Then necrosis, mitosis, increased mitosis. You can see even in this field, there are 2 to 3 mitoses in a single field in this case. Then capsular invasion and extrathyroidal extension into the skeletal muscle. There is again a controversy regarding what should be taken as the definition of skeletal extrathyroidal extension. Describe both big vessels, big venous channels, big arterioles or arteries. If you see tumor next to them, most likely that is extrathyroidal extension, and extension into skeletal muscle is definite extrathyroidal. So mention presence of tumor adjacent to big arteries or vessels or veins, and mention that there is no skeletal muscle involvement, but mention that there is involvement of these structures, and record it as your extrathyroidal extension. Record both. And then angioinvasion, in which we have specific criteria for identification of capsular and angioinvasion. So for capsular invasion, only when it has gone beyond the capsule, even though there might be a pseudo capsule around that mushrooming out lesion, there may be a pseudo capsule, but only when it has gone beyond the capsule will you call it capsular invasion in a follicular neoplasm. Something like this is not capsular invasion. Something like this, B is not capsular invasion, I is not capsular invasion, G is also not capsular invasion. But at the same time, please refrain from calling any such lesion with B, I, or G-like pattern as NIFT-P. Go ahead, sample more, take deeper sections, but do not upfront call something which shows B, I, or G-like areas as NIFT-P. It is unlikely to be NIFT-P. NIFT-P should not even show this much. So be very careful about what to call as capsular invasion, and of course, on the other hand, also what to call as NIFT-P. In angioinvasion, it is I will just mention, I'm sure you all know, but this D category, in which there is an endothelial line over the tumor, and the tumor seems to be present within the wall of the vessel. This is one controversial area. Some people do consider this as angioinvasion and the others do not. But this is one area in which, where this angioinvasion or not, it is, controversial. We've not decided whether to call, but something like this E, where you have a tumor thrombus associated with the tumor, which is attached to the endothelium, is a definite focus of angioinvasion. And so is this, which is outside the thyroid capsule, outside the tumor capsule. And this is already has been told to you by Dr. Gosain, in which this is just to show you in summary how do you classify the different follicular pattern lesions of the thyroid. So less than 1% papillae is important. No nuclear of features of PTC, so follicular lesions. Then look at whether it is minimally invasive or early or angioinvasive, encapsulated angioinvasive follicular carcinoma. If nuclear features of PTC are present, then see if it has a capsule or not. If no capsule, follicular pattern, then this was known as the original infiltrative FVPC with the spidery type of infiltration, which Dr. Gosain very beautifully described in Dr. John Rozai's paper. And that is why this category has now been included in classical PTC, because this behaves like classical PTC and is BRAF mutated. And in this entity, these two comprise the new entity which has been taken out of the PTC criteria, PTC subtypes now, which is the invasive encapsulated FVPC, in which you have tumors which have a well-defined capsule with capsular and or angioinvasion, and these are RAS mutated and more close to follicular lesions or follicular thyroid carcinomas or adenomas as compared to classical PTCs. And the NIFT-P, where you will not have any capsular or angioinvasion and you will have complete encapsulation. And now the new criteria of negativity for BRAF has also been added for NIFT-P. And also you can have now NIFT-P diagnosis in less than 1 centimeter and even purely oncocytic lesions. So these are documents which I have already said. Nodes, very important to describe the nodes. Number of nodes, nodal levels, size of largest metastatic, presence or absence of extranodal and nodal level. Distant site involvement, if present, is mandatory. Pathological classification, PTNM, is mandatory, and additional tissues and ancillary studies, if present, are desirable. With that, I will shift to parathyroid very quickly. Coming to parathyroid lesions. So parathyroid often come for intraoperative consultation. So in order to identify parathyroid tissue or to verify a lesional gland, it is important to weigh all of them, even a small fragment that comes for frozen, measure in all 3 dimensions, ink the outer surface, serially section and photograph. Describe outer and cut surface, size, dimension, cut surface. If small, less than 2 grams, submit entirely. If large, without worrisome features, submit multiple representative. Ideally speaking, again, more is better, submit entirely. If worrisome features, which means very large, heavy, adherent to surrounding structures, or the surgeon raises a concern for for a malignancy in the parathyroid, or the preoperative biochemical markers, very high serum calcium, more than 15, very high serum parathyroid hormone levels, all those, then submit entirely after inking the outer surface of the parathyroid gland. It is very important. This is the new WHO classification on the left hand side, and this is the summary of core and non-core parathyroid data set. This thing again, almost the parameters remain the same. Again, clinical information, operative procedure is important. Specimens submitted, tumor site, weight, histological type, tumor dimension, grade, invasion, lymphovascular invasion, perineural necrosis. So extent of invasion, capsular invasion has no significance presently in the parathyroid. Only invasion of the surrounding tissue. It may be thyroid, it may be extrathyroidal, it may be fat. Only invasion of the extra parathyroid tissue is important. Capsular invasion is not taken as a feature of malignancy in parathyroid tumors. But in lymphovascular invasion, you have to document both of them separately, lymphatic invasion as well as vascular invasion within the tumor capsule or outside the tumor capsule. Necrosis, mitotic count, lymph nodes if present, and then again histologically confirmed distant metastasis and pathological staging. Then it is preferable to do parafibromin staging. One important INSM1, which is a new marker for neuroendocrine and neuroectodermal differentiation tumors all over the body. For reasons not entirely known, INSM1 is entirely negative in all parathyroid lesions. So parathyroid adenomas and carcinomas are negative for INSM1. And that is an important fact when you are trying to distinguish a parathyroid lesion from a neuroendocrine lesion or of any other site. And, or if you're trying to diagnose a parathyroid lesion at a metastatic site. This is the essential criteria for parathyroid neoplasm. As I said,
Neha, can we wind up fast, because I think we're really done.
One more slide.
Thank you. Thanks. Wonderful presentation.
Thank you. So this is one of our cases, just to show you a gross of this thing. This was a lesion which was suspected on FNA as query parathyroid, query thyroid with atypical features. And as you can see, this was almost in this picture, it may not seem that way, but it was like an 8 to 10 centimeter lesion, and this was pearly white, these areas, and then there was some surrounding thyroid tissue at the periphery. However, this nodule looked separate. This nodule looked different. So if we sampled only this area, the white area, this was like an anaplastic. You can see a very undifferentiated looking sarcoma. But only when they sampled this area, this different looking, pale brownish area, that we discovered that this was actually a parathyroid carcinoma, which was having this kind of an anaplastic transformation, so to say. So this is, present terminology is not clear. This is only 2 more cases are reported in the world. So this is actually a parathyroid carcinosarcoma. So just a case to show you, it's a very odd case, very rare case, but just to show you that even for lesions in the thyroid, in the parathyroid, submit all different looking areas for a proper categorization of the lesion further on. And this is just one slide on paragangliomas, which are another endocrine neoplasm in the head and neck region. Again, it is actually metastasis, which classifies a paraganglioma as malignant, and SDHB IHC should ideally be done in all cases, because it helps us differentiate the familial and the genetically determined paragangliomas, which are more likely to turn malignant than the ones which are sporadic. Rest, extent of invasion, lymphovascular, margin status, proliferative fraction, all those parameters stay standard for whatever neuroendocrine tumors we have seen, or other tumors that we have seen till now. So this is just to show you in gist the grossing of all the neuroendocrine related and thyroidectomy specimens of the head and neck region. My acknowledgements, Dr. Asavri Patil, Dr. Munita Bal, Dr. Swapnil Rane, and Dr. Katha Kante, my colleagues in head neck pathology, DMG at Tata Memorial. Dr. Gosain, this talk cannot end without thanking him. In whatever little time I spent with him at MSKCC, he literally opened my eyes to the beautiful world of thyroid pathology. All the colleagues, residents, and histotechnicians in my department, and definitely my head and neck disease management group at Tata Memorial Center, which always push us to do more and better. Thank you. With that, I would love to take questions.